Afternoon, ladies and gentlemen. Welcome to this session. It's a busy day, and it's a miracle that we're actually all here at 2 o'clock, just about on time, so thank you very much. Two co-chairs, Mr. Bipin Zamvar, who's a surgeon in Edinburgh, as you know, mixed practice and off-pump surgeon. Professor Taggart is well known, so needs no introduction. And I'm Simon Kendall from James Cook Hospital, who's done some off-pump surgery, but also is ceded to my colleague who's much better at it than I am, and I train on-pump. So that's the panel. So David, do you want to introduce the first speaker, okay, or Vipin, you ready?
Okay.
And I could just make the general comment. I think the number of people in this room reflect a growing disinterest in off-pump surgery. But anyway.
Okay. Before we start on with the speakers, we have a gift for Professor.
Thank you.
For Professor Christian Hand. Christian Hand. This is for the talks that he gave earlier on. And you have a choice, Christian. You have a choice of whiskey or a glass.
Rather glass is difficult to get.
Okay.
Thank you.
So our first speaker today is Miguel Sousa, who's going to talk on why off-pump CABG is good.
Thank you very much. Thanks for the invitation. I would like to thank David also for sending me his slides in almost all presentations, and we have discussed a lot about this previously. So my task is a little bit hard. It's I'm going to defend OPCAB in this debate with John Pepper. Very, very difficult task indeed. So these are my conflicts of interest. I'm a consultant cardiac surgeon and perform more or less 90% of my patients off-pump. These are the contents. So the present situation of OPCAB in the world, in Europe and the US, is around 15 to 30%, whereas in the East, you know, the figures are here, and are above 60% of the patients are performed off-pump. The situation in the UK, coming from the database from this society, shows that in 2012, OPCAB was performing 19% of the patients. So this is the situation that we have today. There is a current debate, despite being that the off-pump was introduced in the 90s. Are we any closer to a resolution? Editorial by David and Douglas Altman. And is the last word out? I don't think so. We will see. And this is the paper that maybe has sparked this debate today by Harold Lazar. Should off-pump coronary bypass be abandoned? So definitely we are on the defensive. So you all know that the randomized controlled trials are the gold standard for the evidence. There are no bias. However, they have potential weaknesses. Small number of patients, the eligible population are selected, so and there are also crossovers. On the other hand, registries, particularly when they have multivariate adjustments or propensity matched techniques, provide an evidence that is more real world, and it's based in a much larger sample. So on the other hand, they may have confounding bias not properly addressed by the statistical analysis. First, what are the randomized trials? I will go quickly because John will come also on this, so and you know the papers, so I won't go into detail. The first one is the Ruby trial, published in the New England in 2009. And 2,203 patients were randomized to off-pump and non-pump. And here are the results. As you see at 30 days, no difference, but however, at 1 year, a higher composite event in the off-pump patients with 9.9 versus 7.4%. What are the problems, however, with Ruby? This was a trial where in the protocol, it was said at least 20 off-pump procedures, including some in which complete revascularization was performed for all vascular territories of the heart. This is astonishing. The OPCAB experience of the surgeon, median 50 and the average of 3.3 per year. Conversion rate of 12.4% from the off-pump to on-pump, whereas the mean STS is around 3%. Also, the low-risk patients that were included with the estimated 30-day risk of death of 1.9%, and clearly a failure of standardization in completeness of revascularization, whereas an equal planned number of grafts, there was an unequal number of grafts that was performed. And so, definitely, Ruby showed that OPCAB performed by occasional off-pump teams is inferior to on-pump surgery. The other trial that you all know is the Coronary Trial. This is an expert-based trial where patients, 4,752 patients, with the surgeons were required to have performed more than 100 off-pump procedures, and the mean number of grafts, however, was a little bit lower, 3 versus 3.2, and the results are summarized here. The results first at 30 days, where you see that there is no difference in the major combined endpoint, nor in the subset of each of them, and there are a lower risk of respiratory failure, significantly favoring off-pump, and renal injury. However, there was a higher risk of repeat revascularization. And at 1 year, survival curves the same, similar, and no difference in the need for repeat revascularization, neither on the primary endpoint or each of their components. Interestingly, is the subgroup of this trial, although subgroup is always a controversial issue, is that, see that in diabetes, we approach statistical significance here, favoring off-pump. And we see that the higher is the risk also here, although the numbers are small, so it overlaps the central line. You can see that the higher the risk, the most the off-pump benefits patients. And also, here you can see that for single vessel disease, off-pump clearly outperforms on-pump surgery. So the coronary trial, in summary, was designed to show that off-pump could reduce the expected on-pump event rate of 8.9% by a relative risk of 28%. This is quite high. I think it was a little bit too optimistic in a population that includes low-risk patients, since more than 80% had an Euro score less than 5. Other thing was that there was a huge regional variation, whereas off-pump benefited clearly in South America versus no improvement whatsoever in India. And there was also an interaction regarding the Euro score, with higher Euro scores being almost statistically significant in favor of off-pump. And the adjustment for difference in Euro score eliminated variations according to the region. And this was due to selection of higher risk patients in South America compared to India. So the other important randomized trial, very recent randomized trial, was the GOPCA trial in German, multicenter German trial that was included only patients more than 75 years of age, 2,539 patients, and also very important, surgeons were experienced, since they have a median 322 off-pump and 578 on-pump. Predicted mortality, however, this is considered as a high-risk population. But then when you see the predicted mortality, it's only 3.8%. So the mean number of grafts, although it's very near, this is statistically significant. And what are the results? 30 days results, you see that there is no difference in the primary combined composite endpoint, but there was a higher risk of early repeat revascularization with the off-pump. And at 1 year, none of neither the primary endpoint nor each one of its components had any statistical difference. And particularly it is interesting to note that there was no increase in the need for repeat revascularization. So what does second meta-analysis show us? Trying to get more patients so we can get more events, so try to see if there is or there is not any significant difference. This is one of the most important big meta-analysis that was published in 2005 by Chang and co-authors in Anesthesiology, and that showed that it compared in randomized trials and non-randomized trials in high-risk patient studies. And you see this in blue, randomized trials. None of these events, none of these endpoints was statistically significant, whereas for the observational high-risk patients, you see that all favored off-pump. Regarding these endpoints of transfusion, AFib, inotropic support and respiratory infections, not only high-risk patients, but also the randomized trial showed that off-pump brought a benefit, an early benefit for patients. So this was in 2005. But then came, in 2012, a Cochrane Database of systematic reviews published by Moller, where 86 trials were reviewed, more than 10,000 participants, and showed that UpCab mortality was significantly higher than OnCab. And UpCab had fewer distal anastomosis, and there was no significant difference in MI, stroke, renal insufficiency, or reintervention. And the authors concluded that they could not demonstrate any benefit of off-pump regarding mortality, stroke, or myocardial infarction, and that they observed long-term survival was better in the patients that were operated under systems of the pump. And that based on the current evidence, on-pump should continue to be the standard surgical treatment, and off-pump could be unacceptable when there are contraindications for cannulation of the aorta in CPB. However, we must also remember that trials enrolled mainly low-risk patients. The surgical expertise and experience of these trials, of the surgeons, was unknown, and conversion rate went from 0 to 27%. The heparin dose was reduced in the off-pump group in 44 trials, and the long-term survival was considered just over 30 days. A very important also and recent meta-analysis is this one from Koos, where they looked at 38 propensity match studies of 123,000 patients. And I thank David for collecting this data, because this is one of his slides. I think it's particularly very nice slide that shows you that in these huge meta-analysis, you can demonstrate a significant benefit for mortality with an odds ratio of 0.67 and a number needed to treat of 189 patients, that benefit from off-pump. The same for stroke, renal failure, intra-aortic balloon pump, inotropic support, pre-op for bleeding, transfusion, and wound infection. You'll tell me it's not randomized trials. It's true. It's a meta-analysis of propensity score analysis studies. So, in conclusion, this was the conclusion of the meta-analysis. Another important meta-analysis published in 2012 in the European Heart Journal by Afilaro and co-authors. 59 trials, 8,900 patients, no difference for death or myocardial infarction, but a significant 30% reduction of stroke, 1.4 versus 2.1, regardless of age, sex, number of grafts. So what are the issues against off-pump? More repeat revascularizations and may probably a problem with graft patency. This is a meta-analysis by Takagi in the Interactive Journal in 2013 of 12 randomized trials, where definitely there were an increase in repeat revascularization with off-pump relative to on-pump. What about graft patency? The same authors, Takagi, published in 2007 a paper that said that off-pump sacrificed graft patency, and these were the results. And the Ruby trial had a study analysis also of the patency at 1 year, and the number of patients with occluded grafts was higher in off-pump. Overall, graft patency was lower, 83% versus 88%, etc., etc. But you heard what I think about the Ruby trial, although the authors say that this represents real world. Maybe true. So is this due to the learning curve? Is this due to the loss of the antiplatelet effect of the cardiopulmonary bypass? We don't know. This is another study from the UK by Angelini and his co-authors that followed this randomized trial that they published called the BACA studies at 7 years, 199 patients, and they went multi-CT scan, and they showed that the overall graft patency was not different between the two groups. No difference in survival, and survival free from MACE also no different at 5 years, a little bit higher in off-pump, but not different. And this is the summary of their patency. Numbers are small, I agree. Saphenous vein, 10.9 occluded in the CPB group versus 14.9, not statistically significant. And this is the Kaplan-Meier curves of the event-free survival, no difference between the two groups at 7 years follow-up. I performed myself a single surgeon randomized trial, 150 patients, with the early patency assessment by multi-CT scan. What I've observed is a higher patency for all grafts operated on pump at 5 weeks after the operation, although there was at that time a difference in the heparin dose in these two groups, and after heparin adjustment there was no significant difference. Another study that's looked at the patency by the group of Emory in Atlanta showed that there is no significant difference at the follow-up of 7.5 years in 190 graft patency assessed by CT angiography. What about stroke? Well, I brought this paper. I think it's extremely important. It's a meta-analysis of the risk of stroke with CABG compared with PCI. What does it show? It published in the Journal of American College of Cardiology. 19 randomized trials in which 10,000, almost 11,000 patients were gathered, and CABG had a significantly higher risk of stroke with an odds ratio of 2.9. And this means there is an excess of 7 strokes for 1,000 patients treated with CABG versus PCI. And this is a strong argument cardiologists give to their patients, is you should rather have a PCI rather than a CABG, because during a CABG, even with multivessel disease, you increase the risk of stroke. So I think this is one of the objectives that we surgeons should strive to obtain, is to decrease the risk of stroke. We all know this paper, old paper by Calafiore, that has looked at off-pump and on-pump, and what he concluded was in off-pump, the use of a side clamping provides the same CVA risk as patients in whom cardiopulmonary bypass was used. So if you use off-pump but you clamp the aorta with side clamper, it's useless. So this is where the independent CVA predictors, and any aortic manipulation was a risk factor. This is an important meta-analysis of 11,000 patients from 8 studies that looked at neurologic complications after off-pump grafting with and without aortic manipulation. And what does it show? That when there is no aortic manipulation, you reduce significantly the risk of stroke. So this is a paper by the Zurich team, by my friend Volkmar Falk. What they showed also is that when you use an aortic no-touch technique, you observe a significantly difference in the number and the percent, the rates of stroke. You see no-touch all arterial grafting, or which is the use of pedicle and Y-graft, like represented here, or a heart string, you observe 0.7%, whereas in the partial clamping off-pump, you have the same stroke rate as the on-pump group. So why is the risk of stroke higher? You know, gaseous emboli, activation of coagulation, and all these aggressions to the aorta, cannulation, cardioplegia, cross-clamping, and sites. OpCab should eliminate them all. So what about, very quickly, truly high-risk patients? I won't go. This is the Credo registry, 2,500 patients, and adjusted, this is the projected operative mortality using the logistic error score, and there was a significant, in the high risk tercile, a benefit in the 30-day risk of stroke benefiting off-pump, and the same thing at 4 years. A very important paper that looked at patients with low and high body mass index, recently published, also showed that for patients with very low body mass index, in hospital mortality, you have an adjusted odds ratio of 0.48. This is, of course, retrospective with multivariate adjustment. You have a significant lower risk of stroke with an odds ratio also significantly of 0.3, new renal failure, prolonged ventilation, and same long-term survival. And you see here the body mass index as you go on to the left. The lower it's the body mass index, the wider is the interval here. And another paper by the team of John Puskas in Emory, Atlanta, of 876,000 patients. Also, this is an STS-based study where they compared groups that had more than 300 CABG on-pump or off-pump performed versus groups that had a lower volume. They showed no difference, but they showed that WAPCAB was associated with significant reduction in the risk of death, stroke, acute renal failure, mortality or morbidity, length of stay, after adjustment for 30 patient risk factors. And what you see, the STS predicted risk mortality, as it goes higher, the spread here is wider also. The renal function, patients in renal insufficiency, this is 742,000 patients from the STS database. Propensity weight analysis, UPCAB associated with a reduction in the composite hospital or dialysis, and patients having lower preoperative renal function exhibiting greater benefit. So why are the results discrepanting among these studies?
Can you try and...
Yes, finish. Yeah, sure.
Thank you.
Because I think UPCAB includes a wide variety of procedures, so you mingle all this, you don't take into account different techniques, different doses of heparin, anastomosis techniques, aortic manipulations, and also a problem of number of patients and number of events. And we know that although these reductions seem important, as this paper by Sargent shows, there was no significant difference. So in summary, stay off pump and do not touch the aorta. Yes, however, you have to take into consideration the experience of the surgeons, as this paper of more than 700,000 patients showed, with a decrease in the absolute probability of death performed with UPCAB, performed by the surgeons with the highest volume, and showing that there was a threshold probably associated at the levels of 150 UPCAB operations or more per year. And the same was confirmed by this meta-analysis, showing a significant volume outcome relationship in mortality and postoperative complications. And the same is exactly the same that we see in minimally invasive mitral valve surgery. And this is from the team from Leipzig, that you see that the experience with the number of operations, you have a decrease in the number of complications, and this is a CUSUM analysis that show a regular surgeon, an outstanding surgeon, and the surgeon where you have, despite increasing number, a problem here in the number of complications. So we have some gaps in knowledge. I am concluding, Mr. Chairman. Is UPCAB for all patients or only for high-risk patients? I think if you reduce only for high-risk patients, you have the volume outcome problem. What is the training and surgeon experience threshold? I don't know. I don't have the answer. But I showed you one paper that tried to give it. How do we define proficiency? I think every off-pump surgeon should check his graft patency. What is the impact of completeness of revascularization? We should have adapted antithrombotic protocols. And what about the role of minimal extracorporeal circuits, new circuits, no clamp, eco-guided cannulation, maybe, for surgeons that don't feel at ease. So what are my key messages? In standard risk patients performed by appropriately experienced surgeons, off-pump and on-pump, result in similar rates of complete revasc, short-term and one-year outcomes with the possible exception of stroke. Indeed, UPCAB and strict no-touch aortic techniques is clearly associated with a lower stroke rate. For higher risk patients, the evidence from registry data consistently reports significant clinical benefits with off-pump in terms of reductions in mortality and all major complications. Off-pump is specialized technique requiring dedication, strict rules and expertise to achieve proficiency and good results. Off-pump is here to stay, I think, especially for the high-risk patients, but is not an occasional operation and must be used regularly. I think that it should be monitoring of results, and graft patency assessment is mandatory. And yes, off-pump should not be performed if it means incomplete revascularization and inadequate proficiency. Thank you very much.